Huh.
Okay. I just got it. Yeah. Right. Good morning, good afternoon, and good evening. Welcome to this series of programs on laryngology. Today's topic is, of course, sulcus vocalis. But let me introduce you, first of all, our speakers. Mark Ramakkal. Now, Mark Ramakkal is an old friend of mine. We're going back to some 30 years. We started laser surgery in the 80s. He ran courses in Belgium and I ran courses in the UK. So I'm a retired emeritus consultant in UK. I retired maybe 28, 29 years ago. But Mark is still active, working in Luxembourg. And we authored and edited two substantive books on laser in ENT. So Mark is very well known for initiating a classification of laser surgical procedures for laryngeal cancer, a classification which is now followed the world over. Just one more point. Mark has another commitment. So his topic is surgical procedure will be presented first. So it's a different order, but for a reason. And then we will continue with the remaining part of the Circus Vocalis program. We also have amongst our audience Nirmal Kumar. Mr. Nirmal Kumar is known for establishing the ENT UK Foundation, which is a philanthropic arm of the ENT UK in the country. Now, the foundation's primary aim is to raise funding and support doctors and patients and trainee doctors and research groups with financial support. I think it's a worthy cause, and we really appreciate Nirmal Kumar's work for our profession in this respect. So, welcome, Nirmal Kumar. And then we have Brandon Baird. Brandon Baird is, of course, from University of Chicago. He is a uh, co-organizer with Sachin Gandhi for this uh, program of laryngeal webinars, and we're very really happy the way the program is developed. And uh, Brandon has been he's trained in Stanford University, and he also got his fellowship from Harvard University, Massachusetts General Hospital. So he has a special interest in office-based procedures. And then we have uh, Sachin Goel. I got a bit confused with the name Sachin, two Sachins, but Sachin Goel is from Delhi. Uh, he is a high flyer. Uh, he was awarded gold medal for the undergraduate and postgraduate studies. So he is going to take part in our presentation as well. And then, of course, we have Sachin Gandhi, who's who originated this series with the help of Brandon. And Sachin is a consultant, senior consultant in Mangeshkar Hospital in Pune, which is near Mumbai in India. And he has got a wonderful department, advanced technology. And in India, there are a lot of laryngeal patients, so he's got a very huge workload of varieties of cases. He runs courses which are recognized by Royal College of Surgeons of England as accredited courses, and also he has three scholars under him trained, and these posts are also recognized by Royal College of Surgeons of England. So Sachin Gandhi, of course, is a one who started this series. We had a very good run, and I I've been in England since 1960s as a consultant. I'm emeritus consultant, and we worked together, Sachin Gandhi, because Pune is my hometown. That's why we developed that particular hospital there with Sachin's help. So thank you for our faculty. And the today's topic is an interesting one, sulcus vocalis. I started ENT in 1960, and we had a tungsten bulb on a laryngoscope, so hardly you could see anything in the larynx. And the surgery, transoral surgery, was with the forces which were crude, big forces, and you concentrated on removing the pathology, and that was the primary aim of laryngology in those days. Of course, there was no question about vocalis, sulcus vocalis, but in the literature I found that sulcus vocalis was mentioned as a scar by an anatomist in 1892. So the condition was recognized by an anatomist that long ago. What was the etiology of that, we don't know. But looking at the literature, I find that this diagnosis of sulcus vocalis is a challenging diagnosis, particularly when it is secondary to removal of pathology from the larynx, leaving behind a scar. This scar is very difficult to see unless you look for it, and therefore diagnosis is challenging. And as I see in the literature, I think the final diagnosis is by actually feeling the vocal cord or vocal fold under general anesthetic and see that part of it is tethered to the vocal ligament to underneath. So diagnosis is challenging, and also equally management is challenging as well. Of course, our faculty will tell you much more about it, but these two aspects of sulcus vocalis means that you really need to have a lot of experience in diagnosing sulcus vocalis for a start, at least be aware of the condition. And secondly, whatever treatment you advise by surgery or any other treatment, in the end, maybe success rate is not huge. So this is something that you need to remember. And patients' expectations are increasing nowadays, and litigations are increasing as well in every specialty of medicine. So this is how we're going to approach circular. So let us start with Mark, although our order is reversed. Mark will tell us about surgical management of sulcus vocalis, and then we will go on to the uh, usual format of the presentation. So, Mark, thank you very
Yes,
much.
my
Thank
pleasure.
you. We are ready.
Thank you very much, Vazan. I hope you can see my presentation.
Yep.
Uh, uh, Thank you very much for having invited me. It's always bring to me great memories with all the events we organized together with Vazan and Sachin. Yes, the topic today is sulcus and related lesions, and of course, is still very challenging for all of us. So, having been trained in South Europe, I was, of course, aware of the classification proposed by Marc Bouchaillet, who was a famous phonosurgeon during the 80s, 90s, and beginning of the 21st century, and his phonetrician, Guy Cornu. So they had the concept that everything is starting from a closed cyst, epidermoid cyst, and then for some reasons, inflammation, microtrauma, intubation, you can get an open cyst. And after that, from the healing process, you end up with a limited sulcus. If for some reasons, again, the opening is not only on one side, but on two spots, you end up with a mucosal bridge. If the sulcus is limited in extension, it's still called sulcus. If, according to them again, to this classification of Cornu and Bouchaillet, if it is extended all along the cord, then you have the so-called sulcus vegeture. Vergeture is a French word meaning a furrow, and it was designed like this. So here's some picture of it. Here a closed epidermoid cyst. Here an opening, an open sulcus, an open cyst, ending with a sulcus. If it is extended to all the cords, you have a sulcus vergeture. If you have two openings up on the upper part, inferior part, then you have different aspect of mucosal bridge like this one. And sulcus vergetures can be bilateral. So this is the classification of Cornu and Bouchaillet. Here again, the same classification was taken over by Antoine Giovanni and Alexia Mattei from France. Some years ago, Chuck Ford came with another proposition, a more simple classification of sulcus in three groups. The type 1 disease in atrophy, a physiological variant of atrophy, but with the lamina propria intact. The type 2 is what we are used to call sulcus vergeture, with an atrophy extended to all the vibrating part of the cord. And if it is limited, this is the sulcus. So the difference is that Chuck Ford is including in his classification the physiological atrophy, what Bouchaillet is not. So Bouchaillet was claiming that all the cysts, all the vergeture was congenital, which is certainly not true. Some of them can be, and some of them can be acquired. So if you go for surgery, it's sometimes very challenging. We have limitation in surgery. If what we can promise the patient usually, it's a better resistance of the voice. The voice will be more stronger, more resistant to the fatigue. The patient will be able to speak all over the day if he's a businessman or a lawyer whatsoever. But if the voice is more resistant, the sound will remain hoarse and breathy in many cases. But anyway, if you go for surgery, I do agree, I prefer by far to go for transoral surgery. You have to check carefully what you can see. Here we have obviously a cyst, but we have to palpate and check the two cores because on this side over here, we have a sulcus. So those lesions are usually not unique. There's something alone. There's something on one cord and frequently something else on the other cord. And even in the same cord, you can have the combination of the both lesions. So after that, yes, you will see a video later on where I'm used to open the mucosa from the upper part as much as possible in case of closed cyst and to resect the cyst. The same if it is an open sulcus, I would just do it as I would do for a closed cyst. Here you see the epithelium and here the ligament. This surgery must be carefully performed if you are using the CO2 laser with the new technology, with the so-called AccuBlade. Many people are still to use cold steels. It's up to you, but I must say with the advancements provided by the AccuBlade technology with the perfect focused scanner, in my hands, I prefer to use the laser surgery. After that, you redrape the epithelium, and here we are. As I told you, many lesions are confirmed during exploration. It's not always easy, as Bazan told us, to see them even transnasally with the best stroboscope. We are not always sure. And if you are in doubt, it's better to go for exploration. So here again, the technique for the sulcus now, or extended vergeture. Firstly, dissection of the epithelium, because many people would propose to inject something, but you are just injecting, your substance, whatever it is, fat or hyaluronic acid, won't go exactly where you want it to go. So it's better to start with a nice section of the epithelium. You follow, you want to free out the epithelium, and when the epithelium is freed, then you can complete with an injection, with a bilateral injection. One of the question is, can you operate the two sides in the same time? I would say yes. Some people would prefer to do one side and then the other side. I prefer to complete in one session. So same principle, dissecting the adherence of the epithelium until it's completed. And after that, redraping of the epithelium, and then you can obtain a better closing and a better volume by injecting as much as possible in the deep part of the vocal ligament. Before it was collagen, this day this is hyaluronic acid. And then you put a little, well, I'm used to have a little bit of glue, of fibrin glue, to redrape the epithelium. So it was, I will go faster on this part. Yes, what I wanted to tell you is that if you go for surgery, let's say for an angiectatic polyp, be careful. That can be associated with other lesion once again. And if you go directly for a polyp, angiectatic polyp like this, you can end up by missing another mucosa bridge. This is why maybe this is the limit of the transnasal surgery with fiber-guided laser, because it's quite difficult to identify those lesions transnasally. So a closet cyst. This, by the way, a bilateral closet cyst. And if you go for this kind of surgery, you need to take the time, the patient need to take some time for voice recovery, because, and don't be afraid, it's usually big cyst. So it's not a surprise, it's for the first week, you have the aspect of an atrophy. It's not a poor scarring, it's just normal, because you took something out of this. But thanks to the voice rest and thanks to the voice therapy, slowly, well, I mean slowly, after 3-4 weeks, you will see a better vibration, a better closing. And once again, if you have the feeling that it was too atrophic, then a little bit of hyaluronic acid can improve the closing. So it was the case of a teacher, a young female teacher, and she was complaining of difficult voicing at the end of the day, at the end of the week. And we identified a bilateral sulcus, mucosa bridge, open cyst. It was a complicated case. We did some session of speech therapy, but was of course not enough. And then we go for surgery. So it was the first control before surgery. And then before starting the surgery, we go for exploration with microforceps. Here we have an obvious mucosa bridge, so duplication of the opening. Here we have a thickening with an included cyst. Another open cyst. So it was pretty complicated. So for this case, we decided to get rid of the mucosal bridge first. Some people would like to redrape it, but I don't. I prefer to get rid of it, because sometimes this mucosal bridge is vibrating by itself and inducing some orgasms. So the patient is operated under general anesthesia. The ventilation is performed by jet ventilation. So that's why you don't see any tube. And I'm using the AccuBlade, so the CO2 laser technology, combined with a scanner providing the beam to run along a line. The red is, of course, the aiming beam, and the CO2 spot is running along this line. So here I'm dissecting the adherence. So it's performed a shot by shot, never in continuous mode, always in single shot, so you can control exactly each of them. So if you resect the pocket, you have to fully resect it. Try not leaving any epithelium for not getting any recurrence of the cyst. Here we are. Frequently, the ligament, the superficial part of the vocal fold ligament, or a major part of it, is included in this vergature, but I'm just used to dissect it as much as possible, and before redraping the epithelium. So this is exactly the technique proposed by Marc Bouchaillet more than 25 years ago, but performed now with the CO2 laser technology. And yes, the advantage of it is that you have a very, very low thermal effects, and you don't get almost no bleeding. So it makes your life easier than with cold steel. Then the other coat in the same time. I prefer to do this because if you do the two sides, the two vocal folds in the same session, it's only one general anesthesia, one voice rest, and one post-operative speech therapy. So for me, it seems that is more efficient. So you see here, we are completing the resection of the epithelium included in the open cyst. But we discussed about scar. Vazan mentioned that sulcus were firstly identified as a scar. I would say in case of vocal fold scar, I mean lesion involving the lamina propria, I would proceed exactly the same. So from the therapeutical point of view, if you go for surgery, it's very, very, at least in my end, very similar. So yes, a little bit of glue for redraping. And this fibrin glue, this seal, I try to cover to improve the closing as much as possible. It's ambulatory procedures. The patient can leave the hospital the same day. So as you see on this video, there's still asymmetry. There's still vocal fold asymmetry for the patient. The vibration being better, is less difficult to keep working all the week long with the students. And from the efficiency point of view, she's much better. That's what she wanted. So is to show you that, I hope it will work, that, no, it doesn't work. So it was a patient over here that I operated some 12 years ago. And then she went to the south of France. It was the aspect at the time. She spent something like 12 years in the south of France. Then she went back, and I had the chance to check it again, and that was exactly the same like 12 years before. So there's no recurrence. You will hear the voice.
Quelle importance vous donnez à votre voix dans la vie quotidienne, en
Je
général?
n'y pense pas trop, je vous avoue. Enfin bon, je suis contente.
As you can hear, the voice is more regular without forcing, but still a little bit breathy. This is typically the case with this kind of sulcus, but as she's saying in French, for her, the voice is more efficient, is still staying efficient from the surgery time.
Il y a peut-être juste une chose, comme je le disais tout à l'heure, quand on parlait à voix basse au bureau, là, ça coince un peu, je dois chuchoter parce que j'ai des difficultés à parler à voix basse.
Ouais.
Et donc mes collègues pensent que je parle sur elle, alors que bon, je leur explique.
And what she's also mentioning is that for her, using a very low intensity voice is difficult. Why? Because the vibration is not perfect. So to initiate the vibration, they need to press a little bit more to develop more pressure. So we don't need to operate all the patient. Here, she's one of my students. She was a speech therapist.
En tout, ça fait combien de
séances?
J'ai pas calculé.
The same kind of breathy voice, but she was treated only by speech therapy. So the first, you should start firstly with speech therapy.
15 ou 20 séances.
15-20
séances.
Et qu'est-ce que ça t'apporte comme confort?
If the patient is happy with this, that's fine. If not, go for surgery. So as she said in French, she underwent for something like 10 sessions of speech therapy, and for her that was enough.
Mais déjà, elle m'apprend à mieux placer ma voix. Donc,
You can speak all the day long.
Dans mon travail de logopédie en journée avec les enfants, j'arrive à tenir des séances entières sur toute la journée, en pensant vraiment à bien placer ma voix et ne pas forcer. Et alors, tout ce qui est sorti.
And she go with friends to a party. The voice is still there the day after. Yeah, it was a vibration with an acid frequency. You see, it was more involving the left cord. So in summary, sulcus is very challenging, mainly the extended vergeture. There's no ideal treatment so far. And in my hand, the best way is to, after speech therapy, to free the epithelium, and then if need be, to inject something. Presently, the best substance so far is the uronic acid. We don't have the ideal substance to reshape the lamina propria, but maybe hopefully in the next coming years. Thank you for your attention.
Thank you, Mark. Mark will be going soon, so any of the audience have any questions? Or Sachin Gandhi, you have any questions received from the audience? Then we can let Mark go. But Mark, can I ask you a question
Please.
for myself? You got the epithelium and then you got lamina propria. If there is a lesion of lamina propria, you remove that, the healing is going to be by scar.
Well, if you go for surgery, you're inducing a scar de facto, because an incision is a scar. But what you hope is that by dissecting the fibrosis, reshaping the epithelium, injecting uronic acid, and thanks to the speech therapy, you will get a scarring process, but you hope that the vibration will be better. So it's not perfect by far. It's not really perfect, but usually you improve this vibration, you improve the closing, and that give more efficiency to the voice of the patient. So it's not ideal. I fully agree, but this is the best way to do. So, and this is a good comment because as there was a speech therapist in Madison, Wisconsin, Thibault, I don't remember her first name, Susan Thibault, and she recommended 5 days of voice rest, and then after that, restarting voicing with a low intensity voice, just to guide, in a way, to guide the vibration, to guide the healing, it not coming back to the previous huge scar, I would say.
So I think management wise, there are three different ways, isn't it? To first of all, diagnose, very important. And I would suggest to all laryngologists that whichever case you get on the table under anesthetic, take a little pledget, wet it, and then try to move lamina propria on the cord and make sure that you got a diagnosis right of sulcus that way. Either sulcus or not sulcus is only by moving the lamina propria with pledget that you see that it's not stuck underneath. So that's the first, I think, message that you get from your presentation. And the second message is there is excision of scar. And of course, the new methods are regenerative medicine, in which you try to form new lamina propria. And finally, I think that whether it's coming or not, it might be coming with stem cell and etc. with regenerative medicine. I think because you need to regenerate lamina propria, which is lost, to
Yes.
get full fibrosis.
In south of France, Antoine Giovanni is used to inject PRP, plasma and enriched in plaquettes. I don't know, in platelet enriched plasma, and he says that give a better results in the long term. I have no experience with this PRP so far.
Now you know, you and I do the laser surgery, of course I did, but there is a new modality which is photobiomodulation, PBM. That's a low-level laser therapy. It used to be called low-level laser therapy. It's now called photobiomodulation. And in photobiomodulation, you just get a regeneration of cells. So that's something that there's been nothing in the literature about it. There's plenty of it in different part of the body, skin, veterinary science and all that. But I don't know whether that will be the way forward to regenerate lamina propria with photobiomodulation technique, PBM. So that's something that maybe with the future. So if there are no further questions, can we thank Mark very much for
Thank you
finding
very much,
time
Bhavan.
amongst his busy schedule. And I must say, Mark's work over the years have been really excellent, methodical, explaining properly, and beautiful pictures, wonderful pictures. All those years that I knew, your work has been wonderful. So, Mark, thank you very much for your
My
time.
pleasure, Bhavan. Thank you, all of you. Thank you. Have a good meeting.
We'll bump into each other sometime, somewhere. Yeah?
Hopefully.
Thank you.
Bye-bye. Bye.
Thank you. Thank you. We now go to our normal way of presenting any topic. So we now have Sachin Goel, who is from Delhi, and he's going to tell us about etiology, pathophysiology, clinical features, and classification of sulcus foccalis. So thank you, Dr. Sachin Goel. Thank you.
Thank you so much, sir. A very good evening to everybody. I would be covering a brief introduction of sulcus foccalis under the following subheadings, as mentioned by Mr. Oswal. Now, sulcus foccalis was first described by the Italian anatomist Giacomini in 1892 as a longitudinal invagination of the vocal fold epithelium due to decreased or absent superficial lamina propria. In this image, we can see that the epithelium is invaginating into the vocal ligament, and there has been an atrophy of the superficial lamina propria. There occurs a migration of the vocal fold epithelium into the normally convex superficial lamina propria, or deeper. We have to note that it occurs parallel to its free edge and adhered to the vocal ligament and even extend deeper to the muscle. In this image, we can see a bilateral sulcus vocalis, which is parallel to the vocal folds. In this video, please appreciate the medial furrows on the bilateral vocal folds. Coming to pathophysiology, Hirano and Sato performed electron microscopy in sulcus to understand the mucosal changes and reported the following. There is an increased thickness of the basement membrane, multi-layered aspect of the lamina densa, and decrease in the quality and quantity of the elastic tissue. This reduces the elasticity of the vibratory mechanism because of the alteration in the relationship between the body of the fold and its cover, hence inhibiting the normal propagation of the mucosal waves. This leads to two things. Number one, bowing and stiffness. Now, bowing makes the vocal cords appear curved, leading to glottic incompetence. Hence, some air leakage occurs, which leads to a breathy voice. And stiffness occurs due to adhesion of the bottom of the pouch to the vocal ligament or deeper. This leads to irregular and asymmetric vibrations. This is sometimes compensated by a hypertonia of the vocal folds. Sulcus vocalis has a two-pronged etiology, congenital and acquired. Bushire and Cornut in 1985 suggested that it occurs due to a faulty genesis of the fourth and the sixth branchial arches. This was supported by early onset of dysphonia in 55% of their patients and the presence of sulcus in children. They suggested that maybe it occurs due to rupture of congenital epidermoid cysts. However, in 1983, I2 suggested that the onset in their patients was most often after the age of 40 years. And it occurs due to voice overuse, such as in high-pitched singers, teachers, due to chemical exposure, laryngopharyngeal reflux, allergens, intubation-related trauma, and so forth. The trauma to the vocal fold leads to vocal hemorrhage, which heals to form the sulcus. Now, how does the patient present to us? Please listen to this audio sample.
माझं नाव मयूर पाटील आहे. मी काम करतो मगरपट्ट्यामध्ये. फायनान्स कंपनी आहे. आणि मी धुळ्याचा आहे प्रॉपर.
So we can see that the patient presents with a hoarseness of voice with a lot of strain. Patient has to make a lot of effort to produce voice. There is easy vocal fatigability with a weak voice and breathiness associated to it. The voice is most often high-pitched, which is better appreciated in males. On sustained phonation, we can appreciate the breathiness in the voice and the high pitch.
माझं नाव मयूर.
Now coming to voice analysis. On doing the analysis using the MDVP program, we often see that the fundamental frequency, that is the F naught, is higher than what is expected from the patient's age and height. Also, there is an increased soft phonation index, which is a marker of glottic incompetency that leads to the breathiness. There is also increased jitter and pitch perturbation indices, as we can see in the diagram that they are out of range. This usually occurs due to the marked variation and perturbations in the frequency. Because there is a lot of air leakage associated due to the glottic incompetency, there is a maximum phonation time which is much reduced than normal. Coming to stroboscopic examination, we can see here bilateral medial furrows on the medial edges of the vocal folds, leading to a phonatory gap, which is spindle-shaped, and the free edge of the vocal folds appear bowed. The mucosal waves due to adherence can be asymmetric or reduced. It is better to visualize these medial furrows during inspiration, and sometimes we can also appreciate a compensatory hyperfunction of the supraventricular or the ventricular folds to compensate for the phonatory gap. On high-speed montage, we can see a spindle-shaped phonatory gap, which is present in all the images with an open face predominance. And on chymography, there is a persistent gap with the notched appearance of the medial vocal fold edge. This notch is the marker of sulcus vocalis. Now coming to classification, as already Dr. Remarkable has mentioned, the most common classification used is the Ford's classification, dividing sulcus vocalis into type 1, type 2A, and type 2B or 3. Type 1 being the physiological variety, type 2A also known as sulcus virgatur, and type 3, which is also known as sulcus vocalis proper or the open cyst type. Coming to type 1, it is the physiological sulcus, which is the most superficial type. The vocal ligament is not involved and hence it does not have much functional impact for the patient, and it is often not considered pathological. Here in the diagram, we can see that the epithelium has not invaginated into the vocal ligament and the ligament is free. Hence, there is not much adherence of the sulcus. On stroboscopy, there is a minimal phonatory gap, hence leading to no functional changes for the patient. Now, coming to type 2A or the sulcus virgatur, it was named so by Garel in 1923 as a French term for stretch marks. It results from a congenital failure of development of the Rinke space or acquired atrophy. It consists of disappearance of the superficial lamina propria with extension into the vocal ligament. Hence, due to the adherence, it has association with the moderate dysphonia and the patient presents with a spindle-shaped phonatory gap. In this image, we can see a bilateral sulcus virgatur in the patient. The epithelium invaginates into the vocal ligament, creating a deep sulcus appearance. On stroboscopy, on inspiration, we can appreciate the medial furrows along with the spindle-shaped prominent phonatory gap. Now, coming to type 3 or 2B, which is also known as sulcus vocalis proper. This is referred to as an open cyst or a pouch type of sulcus because there is a marked loss of superficial lamina propria. The invagination extends deep into the vocal ligament and may even extend into the muscle. The epithelium around it gives it a thickened and a hyperkeratotic nature. The phonatory gap is more with severely breathy and high-pitched voice. Due to this breathiness and the air leak, vocal fatigue is very common with a reduced marked phonatory time for the patient. In this image, we can see a bilateral sulcus vocalis proper. Now, this marked atrophy of the superficial lamina propria and invagination into the muscle is what is responsible for the open cyst or the open pouched appearance. On stroboscopy, we can see the open pouch or open cystic appearance on bilateral vocal folds. And on phonation, there is a marked phonatory gap. Also, one should note that in this video, we can clearly see the ventricular hyperfunction in the form of anterior-posterior collapse or anterior-posterior compression as a compensatory mechanism for the sulcus vocalis. Now, another very important entity that needs to be differentiated and understood from sulcus vocalis, that is the pseudosulcus. Pseudosulcus is the subglottic edema that extends from the anterior commissure to the posterior larynx and running across the length of the vocal fold. Mind you, the sulcus occurs on the superior surface of the vocal fold whereas pseudosulcus is noted below the vocal fold in the subglottis due to edema. It is most often associated with laryngopharyngeal reflux. Here, we can appreciate the bilateral pseudosulcus in the patient running across the complete length of the vocal folds. Mucosal bridge. Another very important association of sulcus vocalis needs to be understood. It's a benign connective tissue abnormality that extends over the free surface of the vocal folds and are attached to the front and the back of the vocal fold. They can be complete or incomplete, complete further being divided into thin and thick varieties. They are most commonly associated with sulcus and cysts. In this video, we can see a bilateral sulcus and the mucosal bridge being carefully dissected and delineated from the sulcus using a sickle knife. This adherence of the mucosal bridge makes it a very important entity to diagnose, identify, and treat during the sulcus surgery for optimum outcomes for the patient. These are my references. Thank you so much.
Yeah, you can hear me now and you can see me as well. Thank you. Thank you very much, Dr. Goel. I think we will wait for the questions right at the end. Any questions for the audience? Can you hear me? Can you hear me? All, yeah, okay.
Yes.
So just to make a point about the vergeture, the term stretch mark comes from postpartum abdominal marks that women get after delivery. They're the stretch marks. And the French word comes from vergeture. It used to be called for those stretch marks. And the person who gave the name, his name arises from there, okay, stretch marks. Just a further little bit of information about that. So the next speaker is Brandon. Brandon is going to tell us about the role of PRP and basic fibroblast growth factors in surgical management of sulcus vocalis and importance of vocal hygiene. Now, that's an interesting topic because fibroblasts grow and they make more fibroblasts. So let's see what he has got to say. But again, going back to what I was saying, you have an active management of removal of scar, but then scar will be replaced by scar. But you want to reform the lamina propria, so you need to introduce something different, a growth factor or whatever else. And as I was saying, it's photobiomodulation, something that has not been tried yet. So let us see what you're going to say. Thank you, Brandon.
Great. Thank you so much, Dr. Oswald, and thank you again to Dr. Gandhi and to DMH and for this fantastic program. I always enjoy having the opportunity to speak here. So a lot of what will be discussed here is very new. It's probably only about less than 5 years old for many of these interventions. They involve injections, and I'll try to go slowly today. I know that I tend to sometimes rush in terms of my speaking, so I'll try to kind of move a little bit slowly. But most of them involve injections, and the role with the injection is to try to expand the superficial lamina propria layer. As many of you saw, this is a defect and a deficit of the lamina propria layer, and oftentimes an adhesion or scarring of the epithelium down to the ligament or deeper, as Dr. Goel so eloquently mentioned. The role of laser, and as Dr. Oswald said, and did some of the remodeling, as well as the surgery, as Dr. Ramacol mentioned, I think has variable results in different hands. I think the question of whether or not just breaking up the adhesions between the epithelium and the ligament, or doing something to resect, which might lead to further scarring. I think it's difficult to tell which is actually ideal, but one of the nice things about the interventions that I'm going to discuss is the fact that it doesn't involve an ablative procedure, or potentially destructive or scarring procedure. It's simply an injection, just as you would have an injection of saline, with a modifier to help expand the part of the vocal fold that has a deficit. So there's a lot of promise here, and I think it holds a lot of great opportunity for addressing this problem, which has historically been sort of a thorn in the side of many of us. So briefly, I'm going to talk about pre-intervention counseling. This is would have been a really good discussion prior to Dr. Ramacol's the talk on surgery, as well as in the discussion of the informed consent process. Again, because of the time constraints, we sort of switched things around, but it applies to both injection interventions and some of this biogel / alternatives, as well as will apply to a discussion of surgery for these patients. And then we'll talk about the endoscopic, non-ablative, non-excisional options for sulcus and scar. And if we have a little bit of time at the end, we can talk about some of the anesthetic considerations for doing this in the office. So briefly kind of moving on to pre-intervention counseling. And before we get there, again, I just want to reiterate what's already been said by Dr. Goel and Dr. Ramacol, that the important thing to realize and recognize is the cover body theory, which sort of, it was initially described by Hirano, but it discusses this movement of a more pliable cover over the body of the vocal fold, which is relatively static, which creates that wave propagation and thus voice production. It's very important that the two layers, both the intermediate, superficial, and deep layers, are intact for appropriate voice and phonation. When you lose part of the superficial layer, you have a lack of movement of that cover along the body. You have a lack of mucosal wave, and thus you have a change to the voice that is, as Dr. Goel mentioned, breathy because of glottic incompetence, strained because of lack of an appropriate vibratory capability of the vocal cord, and can sometimes result in some pretty significant dysphonia. So briefly talking about strategies that people have previously taken when there's been a lack of superficial lamina propria. So consider this yellow layer to be an example or rendering of the superficial lamina propria. Many take the approach of just trying to do an injection to close the glottic incompetence, going from a bowed kind of appearance to a more straight appearance. And what we know that whenever you're placing something in the muscle, the TA, to move the vocal cord over when there's already thinning of the SLP, what you're doing by placing that is actually thinning the SLP even further. And while it can increase the volume of phonation by improving the closure and addressing that gap, a lot of times the quality is sacrificed, and it can exacerbate the thinning of the SLP. So it's really important to, not reflexively only just do an injection of a bulking agent when you see or recognize that there is a sulcus or a scar, or even thinning of the superficial layer of the vocal cord. And it's really important to perform strobes for all of these patients, as Dr. Goel mentioned, to really look for this so that you're not reflexively just injecting if there's a gap. Again, the shortcomings of fat when you're medializing are the same. When you have a thinner SLP, you're not only thinning the SLP more by injecting a bulking agent underneath it, think, a balloon, and you have shaving cream on a balloon, you blow a balloon up, the shaving cream thins. Also, it can increase sort of the effect and worsen the quality of the voice when you have a sulcus that's there. So if you inject fat, or if you put a medializing agent like hyaluronic acid or CAHA behind this, it's going to thin this even further and expose that sulcus a little bit more, which may, again, affect quality. And then finally, our holy grail, what we've wanted for decades now is to figure out a way to expand the superficial lamina propria for patients that have sulcus and scar. If we have the capability of doing that with a modifying solution like PRP or biogel, then we can not only improve the volume by addressing the glottic incompetence that's there, but we can also increase the quality and improve the quality. I'm going to talk about mostly autologous options today since we only have about 15 minutes, and they seem to be the most promising with regard to expansion of the SLP and improvement of the mucosal wave. So counseling, when you're talking to a patient about what options there are when they have sulcus or scar, it's very important for you to be transparent about the expectation for improvement with augmentation. We know that there are limited options. There are a number of people that are working on a biogel or a bioequivalent replacement for the superficial lamina propria, but none exists at this point. We have to talk about the fact that we may have an improvement in volume. However, this might come at the expense of quality, with pitch and strain being affected. Occasionally, if you inject patients with a bulking agent, their pitch will go through the roof and they'll be very high and strained. Some people are willing to take that trade. Some patients, especially singers, should be very thoroughly informed about that potential risk. It's very important to discuss the role of voice therapy, as Dr. Ramakol mentioned, both before and after addressing this phenomenon. And it's important to make sure that you have appropriate voice measures where feasible, both before and after objective voice recordings, before and after, so you can show the patient what the degree of improvement has been. And it's important to have extensive discussions about what the cause of this sulcus is, either congenital or in certain circumstances post-surgical or potentially radiation-induced. So with informed consent, it's very helpful. It's important for the patient to understand the risks, but for you to explain sort of things that they may not have the most health literacy in terms of understanding. So it's important that you have a cadre of videos to present to the patient, to show them other patients with similar conditions. It's also important to show those videos of patients who did not have an improvement after, say, scar excision or, say, injection of PRP. And it's important to really note all the risks that go along with this. Like I said before, videos can be helpful, and certainly pictures can give 1,000, can give you 1,000 words or better than 1,000 words. It's important to talk about the published history of the intervention. For instance, a lot of what I discuss here is very young, and so having long-term results in terms of decades is not feasible just yet. You also have to stress the fact that there may not be one fix. There may not be one quick magic bullet that improves things, and that these patients may require multiple or serial procedures to improve the quality of their voice. Of course, risks of SML or suspension microlaryngoscopy can be helpful to discuss as well. So let's briefly just kind of go right into some of the alternatives that we have for SLP restoration as it stands at this point. So fat injection was sort of the oldest known restoration option, and it's been around for multiple decades, about 20 years or so. However, more recently, things have shifted towards injection of a various solution or agent, fibroblast growth factor, hepatocyte growth factor, activated fibroblast, platelet-rich plasma, and bioengineered voice gels are all sort of on the horizon at this point. Lipo injection has drawbacks because the pliability of fat when injected into the vocal fold is not the same as the pliability of the superficial lamina propria. So oftentimes a fat injection in a superficial space can oftentimes lead to a worsening of the voice. So it's very important, if you're using a specific material like fat, that it's injected into the deeper layer within the muscle itself rather than the superficial lamina propria. Our holy grail is actually the extracellular matrix or bioengineered voice gel. We just don't have the capability of doing that yet. And this was sort of, this need for a biogel or an SLP replacement was identified all the way back in 2008. Clark Rosen and Blake Simpson published this book. And in this book, they talk about the superficial vocal fold injection and specifically say that the most commonly used injections are materials like Symetra or Cosmoplast. This was back in 2008. However, they were all temporary in nature, and they also can induce sometimes new native protein recruitment. However, it's likely that a new lamina-appropriate substitute will be developed in the near future, which may be able to be delivered via superficial vocal cord injection. Cross-linking hyaluronic acid-based substances have not proven to be any value when placed superficially and are thus contraindicated for this procedure. The reason being, when you inject hyaluronic acid into the superficial layer, that hyaluronic acid stays there and has a very prolonged residence time. And again, the pliabilities, the plyometric properties of the hyaluronic acid are not favorable in terms of making appropriate sound. So briefly, we'll talk about fat injection, then we'll move to some of the other newer options. So in 1911, Brunings was one of the first to document repair of vocal cord immobility, and this was used more for a glottic incompetence related to a vocal cord immobility. He used paraffin, which was subsequently found to cause a foreign body reaction similar to Teflon, paraffinoma. Subsequent to that, Cheng described the experience of using autologous fat for glottal insufficiency, and this was in 16 patients with vocal fold atrophy and in 8 patients with vocal fold sulcus, with good results in about 15% of patients. This all required an over-injection of the vocal cord because about 40 to 60% of fat was resorbed. So let's look at some of the data of fat injection. So this was a study that Salmeron Gonzalez published back in 2020. They examined 21 patients that were operated on through injection laryngoplasty with fat grafts to treat dysphonia. All the patients were operated on between 2015 and 2019, and they were evaluated via both acoustic measures, perceptual measures, including the GRBAS scale, as well as the Voice Handicap Index 10, and MPT, maximum phonation time, jitter, shimmer, harmonic noise ratio, both before surgery and 8 months later. And the results were pretty favorable in these 21 patients. Mean age was about 57. Of the vocal fold etiology for the scarring, about 17 patients had tumor resection and subsequent scar, and 4 had sulcus vocalis, secondary to presumed congenital reasons. Occasionally, patients received an injection laryngoplasty at the same time. As you can see here, there was a statistically significant improvement from preoperative to postoperative measures after fat injection for both the perceptual measures with the GRBAS scale, as well as for the objective measures, looking at maximum phonation time, looking at VHI, jitter, shimmer, and harmonic noise ratio. Fat injection, as it's performed by me, is typically a lot easier than it has been previously. So harvesting the fat using this system, which is called the lipavage system, has made harvesting fat for specifically lipo injection very easy. What I'll do is I'll create an 1 centimeter incision, just sort of below the umbilicus, and then spread with a Metzenbaum's scissors and use the cannula that's included in this system, attach it to a liposuction suction machine. And the system itself has a netting. I'm not sure if you can see it, but it has this sort of syringe with a net inside of it that allows blood and other solutes solutes to go through, whereas it will keep the fat globules here. It'll also micronize the fat for you, so you don't have to chop it up or do any specific things that can potentially shear the fat. You harvest the cells in the filter chamber. It concentrates. You would irrigate and wash with about 2 liters of saline. And subsequent to that, you can then transfer the fat through a adapter that can be inserted into a 10 cc syringe to transfer the fat back out and into your 10 cc syringe. I then will place a 14 gauge angiocath on the 10 cc syringe, and I will load it into my injection apparatus. I use the Brunings injector. However, there is an Integra injector that's very helpful as well. So what you'll do is you combine this gun, this apparatus here, with this longer cannula, and you'll sort of attach this to this side, and then you'll attach it to this needle here. And what I found to be helpful is when you load this with your 14 gauge needle and your fat, you can load it all the way up to the top. You can then attach it here, prime it so that the the fat comes out of the edge of the needle, and then you can add a little bit more, open this back up and add a little bit more fat, and then prime it again so you're ready to go. When you do this injection, you have to set your microscope working distance at about 460 because of the length and the size of this injection kit. But it works pretty well in terms of adding bulk to the vocal folds. Again, you want to aim for getting it in the muscular layer rather than the superficial lamina propria layer. Serial injections of saline have been discussed as an alternative as well for vocal fold atrophy and loss of superficial lamina propria. The data is somewhat conflicted about the utility of steroids for injection into vocal fold scar. No one's looked at it really for radiation-induced scar, and in some patients there has been an improvement in the VHI with steroid injection. Injections of saline as well, these serial injections of saline, can also be helpful in terms of identifying where the sulcus is. If you inject in just a subepithelial injection, you can see the normal SLP pouch pooches out. However, areas that are scarred or tethered down will remain fixed and will remain sort of tethered with sort of the more apparent sulcus. So that can also help you with diagnostics, as has been mentioned previously, both in the operating room and in the office. Some others have discussed the use of estradiol and dexamethasone for wound healing with patients that have vocal fold injuries. There's, again, not much data to support this, and it's mostly animal studies. When it comes to injection, there's a great injection needle that's available via stores and also one that's available via Endocraft in the United States that has a bevel tip that allows you to more easily inject in the subepithelial space rather than going directly into the muscle, and to be able to see the result of it. Fibroblast growth factors and activated fibroblasts are another sort of series of interventions that have come along over the past 4 years or so. In this study by Hirano, that was published back in 2001, they looked at patients that had, quote, vocal cord atrophy and or scar or sulcus. All demonstrated improvements in perceptual measures, PPROMs, such as the VHI-10, and then some of the more objective measures like MPT. They had improvement, but they were statistically significant. However, there was some inconsistency and some variability in the results, but for the most part, this was promising. This opened the door for a number of other people, or same group, but a number of other people to think about other growth factors that could be injected. This was a phase 1/2 clinical trial that looked at injection of hepatocyte growth factor into the vocal cords using a dose escalating strategy, open label, and was first in human trials. Patients received 1 microgram, 3 micrograms, and 10 micrograms of the injection administered once weekly for 4 weeks in a dose escalating fashion. And the results indicated no serious drug-related adverse events in either the systemic or local examination. Most patients had an improvement in the VHI-10. Most had an improvement in the vibratory amplitude on stroboscopy, and also had an improvement in the GRBAS scale at 6 months. Maximum phonation time and jitter varied, and there was no significant difference in the phonatory data between the step groups. So it was also another option that's been sort of hypothesized. Now, one of the other options, and sort of, again, along the same line as FGF that's come along, Yue Ma and the group out of UCLA and Stanford looked at the use of activated autologous fibroblasts. They took 15 subjects and they actually harvested fibroblasts from postauricular skin. They then sent off this postauricular skin and they sent it to this company called FiberCell, which is based out of Pennsylvania here in the United States. FiberCell cultured the fibroblasts from that skin. They expanded the fibroblasts into a cell set, and then they sent it back to the organizations, either UCLA or Stanford, to then inject into the patients that had age-related voice change or scar. And they found that the results were actually pretty favorable. After about 4 months, 8 months, and 12 months, there was an improvement in the appearance of both of the visual analog scale in terms of the self-assessment of patients who had the injection of fibroblasts, as well as an improvement in the appearance of the vibratory capacity of the vocal cords after the fibroblast injection, and also an improvement in VHI. So all of these things sort of indicate that there's some benefit to either fibroblast growth factor, fibroblasts themselves, We just don't know what the answer is and the reason for that, as some of our studies are limited. The next frontier is platelet-rich plasma, as has been sort of mentioned earlier today. And this holds a lot of promise because it sort of takes all of these unknowns that we have from FGF and activated fibroblasts and sort of it gives us the quick ability to harvest them and inject them. So this was a study that Peek Woo first published. I think it came out back in 2013. And then this was followed again by a study by Dr. Johns at USC in 2022, where they injected, as you can see here, in the office using a thyrohyoid approach, they injected activated platelet-rich plasma, which they harvested using peripheral blood peripheral blood. They spun it down in office and then injected it in a series of 4 injections over the course of months. And you can sort of see that there was an improvement in the CAPE-V for patients that had the injection. So put 1 day post-injection, the CAPE-V actually worsened a little bit, but then over time, the CAPE-V got a little bit better and improved. So the system that they used was the Eclipse PRP system. There were a couple of absolute contraindications to collecting this PRP. A couple of them, platelet dysfunction syndrome, critical thrombocytopenia, hemodynamic instability, and septicemia were all sort of absolute indications. Relative contraindications: don't use NSAIDs 48 hours before the procedure, no corticosteroids, no tobacco use, hemoglobin below 10, platelet count below 105. And so very briefly, I'll just kind of show you what the process looks like, and I'll try to kind of pass forward. So essentially what's collected, you collect peripheral blood as you would for IV, for a draw, for a CBC or for a CMP. And you're drawing about 11 mLs of blood is all that's needed. Again, we'll talk later about the preparations and how much this turns into, what this turns into in terms of the supernatant and then subsequent amount of PRP that's injected. It's typically only about 1 ml. So the 11 mLs spins down to 1 ml, and that's what's injected into the vocal fold. So after the 11 mLs are collected, then they're placed in just a simple centrifuge. Eclipse provides this as a great office-based option, and so there are centrifuge inserts for this specific vial, and then there's a counterbalance that's placed. It's spun down, and it's spun at a rate of 3,500 RPMs for 10 minutes. And that does the appropriate sort of task of bringing all of the erythrocytes, the red blood cells, down to the bottom of the tube, and what you're left with is the supernatant. And so if you want sort of platelet-rich plasma, you can either shake, as they show you, and remove the supernatant here. So they'll show you here what's done, inverting the tube 7 times. What people are doing more frequently is removing a lot of the supernatant here before they mix it. So this is even more concentrated. And then collecting this, and then it goes into a syringe, and then it's ready to go for an injection. And depending on how much you need, you can only draw, if you only need 2 cc's, you can draw 2 cc's, and you throw the rest of the red blood cells away. And so that's basically how you collect the PRP. How is it injected? You can do either transthyrohyoid approach, as has been mentioned before, or you can do a transoral approach with a Ford injector. This is a set that comes through Zomed. It's a long metal cannula that goes transoral. Here's another cannula that's used to apply topical anesthesia, and it can be performed with a rigid scope or a flexible scope. If it's a rigid scope, 1 practitioner is needed while someone, a nurse, an MA, or an assistant holds the tongue. If it's a flexible scope, you need someone that's skilled enough to hold the flexible scope while you do the injection. And again, I think you've seen this before, but this is basically the view with the flex scope through the nose with the Ford injector here through the mouth. And then again, a thyrohyoid approach in this direction, or you can do a cricothyroid approach or a transthyroid approach here to do your injection. And again, you've seen this movie before. This is for a paralysis patient, but it gives you sort of the sense and the idea of what things look like. Here, I'll kind of fast forward. What things look like for a transcervical injection. So here we're injecting Restylane for the vocal cord paralysis. So we're going into the muscle. However, for the PRP, you would actually go superficial and inject just under the epithelium here and get an expansion of the epithelium. Here we're going to the muscle because we don't want the Restylane to go too superficial. So moving on to transoral injection. Again, this is a similar strategy, so I'll pass by this here. So Tom, there's a great article that sort of recently come out in January of this year, looking at a comparison of the techniques, preparations, and outcomes after injection of platelet-rich and platelet-poor plasma for laryngeal application. It compares the proposed mechanisms based on available published data, which is, albeit sparse, and it also identifies the need for more studies with improved placebo control and randomization. So 3 of the main studies that have come out, 2 by Wu. The first was in 2013. And then again, BOT, which is the Michael Johns study that I referred to earlier, and then the Wu and Murray study. And again, in terms of preparation, what we're looking at is the anticoagulant that was used, if at all. BOT and the USC group did not use an anticoagulant. They just harvested the blood and then spun it down. Whereas Wu uses citrate dextrose as an anticoagulant. There's a difference in terms of spin protocol. Earlier, 3,000 RPM was what they used, but then they used 100 times gravity for 10 minutes. And again, 3,500 RPM was used for the BOT study. And collection of 1 ml of the remaining PRP was extracted after discarding the top layer of platelet-poor plasma. And then the top layer of platelet-poor plasma was extracted after a second spin. And then it was heated at 100 degrees C for 12 minutes. So a little bit different in terms of the preparation. Again, there's no correct answer here. Looking at the type and technique of injection, so the mode of application for the USC study was a transcervical thyroid injection. And this was also done with Wu. However, the second Wu study used 22 transoral approaches and 10 transcervical approaches. The average amount of volume that was injected was about 0.5 in the last Wu study and about 1 in the first Wu study and the USC study. And the injections were performed for the first Wu study into the muscle. However, in the second Wu study and also the USC study, it was injected in the subepithelial space. And 1 injection was performed and was intended to be 4 monthly injections, but this was limited by the COVID pandemic. And then 2 patients had 1 injection, 1 patient had 2 injections, 11 patients in this study had 3 injections. So there seems to be some improvement or some benefit to multiple injections, serial injections. Then finally, voice outcomes. There was an improvement in CAPE V scores for patients that had the PRP injected in the USC study. There was also improvement in the VHI-10 scores pre and post. And then looking at the outcomes for Wu, again, there was improvement in the perceptual as well as the PROM measures for patients that had injection. And there was an improvement in the MPT and some of the other acoustic measures as well in patients that had the injection. In terms of what improvement there is with PRP, animal models have shown that there's improvement in some of the growth factors, et cetera. But I will pass over this. I know we're running out of time, so I'll just kind of finish up. People have looked at autologous fat plus platelet-rich plasma on sulcus, and there seems to be some benefit of using both fat as well as platelet-rich plasma to improve VHI, improve outcomes, and improve the glottic competence. And then I'll skip over this. This sort of is a little bit off topic, but and maybe discussed by Sachin, but there are benefits to perichondrium and fascia insertion. So that's it for me. Thank you again for the opportunity to speak, and certainly last but not least, we have a lot of missing information. We need more randomized placebo-controlled trials, some head-to-head fat versus alternative injections, cadaveric assessments, et cetera, as well as improved objective characterization.
Just ask you just a quick question. Do you actually remove the scar tissue, or your primary treatment is augmentation?
In my hands, I've mostly done augmentation because of the risk that comes along with the scar tissue removal, and I've had pretty good improvement What I imagine will be the case is that there will be some combination of either, as you mentioned, sort of low energy laser augmentation of the vocal fold subepithelial space to remove adhesions. And sometimes when you even inject, you can see the adhesions popping as you inject in the operating room. So I think it's a combination of probably needing some type of ablative procedure in addition to the injection of these biosimilars or biologic autologous agents. So
yeah, so really, so far we learned that there are 2 or 3 approaches. One is to remove the scar and make do with augmentation, the scar, just augmentation, and then with is bulk, to provide the bulk, or to provide regenerative cells. Is that right?
exactly. And I think more promise
And
falls into the
and
regenerative
when you
category.
say pathology, is it in the superficial lamina propria, or do you have the differentiation of some cases are superficial, others are deeper? They have to be, not
Yeah, of
only
course, some have to
superficial
be
lamina,
deeper. Of course, yes,
the
yes,
fibrosis.
yeah, yes,
So,
exactly.
yeah, okay. We're last presentation, Sachin,
Yes, sir.
and then we have some questions. Okay.
Sure, sir. Yes, yes.
Thank you, Sachin.
Okay. Okay. Good evening, everybody. Now we are just going ahead. Maybe it will be recapitulation of whatever we have seen in last 3 talks, and then some clips and some experience. Yeah. So I think there are multiple methods which have been described, but there is no gold standard. This should be the treatment, and this is going to give you the results. So we can try one or combination of many treatments together to achieve the desired result. So if you can just classify the different methods, let's have the pathology and then what thing would work on that particular pathology. So we can divide the surgical methods, either the direct approach or indirect approach. Direct approach would treat the basic pathology. And what's the basic pathology is loss of superficial lamina propria and adherence of the superficial epithelium to the ligament or the muscle deep down. So basically, the direct approach would reconstruct the pathological defect, that is the adhered superficial epithelium, and injecting something which would regenerate the soft tissue, that is the superficial lamina propria. So these are some direct methods. And what are the indirect methods? Indirect methods would improve the glottic insufficiency, which is induced by the bowing of the vocal cords. So what we see as a result of the primary pathology is bowing of the vocal cords, which gives glottic insufficiency and hoarseness to the voice. So what are direct methods? We have already seen. One, we can say dissection or degeneration of the superficial epithelium or the scarred tissue. So we have already seen this. Excision of the sulcus using either cold instruments, a scissor, a knife, or you can use CO2 laser, which was beautifully seen in Mark's lecture, or you can use KTP, which has been described by some Korean laser surgeons, and then I'm like to talk on this in the future or the coming slides. Then you have to reconstruct the lost superficial lamina propria tissue, or regenerate the lamina propria tissue. What you can do for that? Just approach the superficial lamina propria either transorally or through mini thyrotomy, that is creating a small window over the thyroid cartilage, and you can then impose fat or transfer this temporalis fascia, gelatin sponge, one of my friend, Brigadier Ramlingam, had just used a temporal, this perichondrial perichondrium, a tragal perichondrium, and it has put in the superficial lamina propria just to reconstruct the lost tissue. You can use multiple fillers which can regenerate the vibratory structure, that is the superficial lamina propria. So that's the reconstruction. You can use amongst those the fibroblast growth factors, PRP. We have already seen this in the talk with Mr. Brandon. What are the indirect methods? The indirect methods would take care of the glottic insufficiency which has been caused by bowing of the vocal cords because of the loss of superficial lamina propria. And how they can be corrected is injection laryngoplasty, injection of some fillers like fat or hyaluronic acid, or there are people who are doing thyroplasty 1, medialization thyroplasty on both the sides. One of my friend actually, Dr. Ashok Purohit, he has done maybe around 10 bilateral thyroplasties for bilateral sulcus vocalis. So this would take care of the glottic insufficiency. This would direct method would take care of the lost tissue and creating the vibratory structure. You can combine both of these, which have been described, in which we use. So we just excise, dissect the superficial epithelium, reconstruct it with some fillers, and at the same sitting, you can augment it with fat. So we have taken care of the glottic insufficiency as well as reconstruction of the superficial lamina propria. This is a mini thyroidotomy which has been described to put in fat or temporalis fascia in the superficial lamina or the tissue which has been lost. It's a tricky and skillful surgery because transorally you have to put in the fat, dissect the epithelium, put in the fat and the material there, and take the sutures within the laryngoscope, which is a tricky and can lead to complications like exclusion of the graft material. Like you see here, the fat is really coming out of the suture lines or the sutures. You are taking herniation of the graft material and granuloma formation. So this has become difficult putting in some material within the superficial lamina propria and getting it for a longer time in that particular area. So this is something difficult proposition as yet. Medialization thyroplasty will take care of glottic closure. It would improve the loudness, vocal efficiency is improved, vocal fatigue would reduce, hoarseness or breathiness would really taken care of. But doing bilateral thyroplasty in a mobile vocal cord in again a questionable decision. So what's been practiced and easy to do, easy for the patient also to undergo is autologous fat augmentation in bilateral vocal folds. So this is what we do is fat augmentation. Again, it's going to take care of glottal insufficiency and longer stable voice outcomes. It would reduce the strain and fatigue of the patient. And European Laryngology Society, it recommends injection laryngoplasty to be used as the first approach because it's easy to undertake and good for the patient also to try as a first measure. Fat harvesting we have already seen with the Brandon showing one needle. What we do in our institute is just by periumbilical small incision, just take the fat tissue out, resect the connective tissue from the fat globules, This is done under local anesthesia itself. With the scissor, you can crush the fat to make it homogeneous. Then you can just take pestle mortar and gently pulverize it to make it paste. Then you can take this solution of the paste in 1 cc syringe. This is an insulin syringe. You can attach this needle, which really I have developed and I'm using it for last almost 20 years. You can put in this endoscopically or through the direct laryngoscope and inject the fat. I'm going to show you in your future clips. Now, this is a case of bilateral grade 2 and grade 3 sulcus vocalis. So the epithelium really is going inside across the superficial lamina propria into the ligament and maybe deep down into the muscle. Let's see this clip. So with a sickle knife, I'm going to dissect the adhered superficial epithelium from the ligament below. This is a flap down. It's very difficult to elevate the flap above. So what I have using is a KTP laser to take care of this solution, this adherent superficial epithelium. And with the needle, I'm injecting fat, which will take care of the glottic insufficiency. So we have taken care of glottic insufficiency, as well as we have dissected the superficial epithelium from the ligament below. When we inject on both the vocal cords, after the surgery, what patients may feel is uneasiness, because there is always a heaviness when you inject both the vocal cords at a single sitting. Patient may have transient stridor when coming out of the anesthesia, but don't worry, the stridor settles down in 4 to 6 hours and heaviness in 3 to 4 days. The vocal outcome really can be judged only after recovery of mucosal waves on both the vocal cords. And it takes around 4 to 6 weeks. So patient has to be given modified voice rest for 1 to 1.5 months. We are going to see the results now. So this is a case, this is a stroboscopy, which is pre-surgery, pre-operative, which is showing the sulcus on both the vocal cords, inadequate glottic closure, strained and hoarse voice. This is after the fat augmentation and dissection of the sulcus from the edge of the vocal fold. Now, what you can see is mucosal waves have come back, and you can see the maximum phonation time has increased. That means there is adequate glottic closure, and patient has to, go on with this for 6 to 12 months to have good long-term results. Now, this is the question asked, how much the fat stays for? And to study this, actually what we have done is in series of patients, we are doing MRI after 3 months, 6 months, 12 months, 2 years, 6 years, and 10 years, because these patients do come for follow-up. We started doing fat augmentation around 20 years back. And this is MRI of the patient, which is showing presence of fat in the left vocal cord. So this tells us if the fat really remains for quite a long time, and many people say it's a permanent augmentation, but you can always tell your patient is going to give you long-term benefit. What are the results of fat augmentation in sulcus vocalis? So just to compare various papers, actually this was my initial paper in 2012, in which I documented 13 cases. 9 of them had good vocal outcome after 12 months. These are other papers, and all the papers are really showing outcome at around 60 to 70% for 12 months. Platelet-rich plasma, already Brandon has talked about it. You can mix up the platelet-rich plasma, PRP, with fat and then inject. That's what we are doing in our institute, and it is just giving better results than just injecting fat individually or in the vocal cords. There is again a publication. They have, in a single institution study, they have compared autologous fat only and autologous fat with PRP, and they have seen it remains for longer duration. So it's a long-term result, and VHI is better as compared to really autologous fat only. So basically, the study itself says when you mix up the PRP with fat, it gives better results, and that may be because the PRP helps in the regeneration of the superficial lamina propria, which gives maybe better results. What is the role of KTP laser? This is the new technique which I have started using. It's similar thing. I mean, again, reconstructing and dissecting the superficial epithelium from the deeper tissues. What KTP laser does? Basically, the thermal damage, it induces the scar remodeling. So it initiates, again, stimulates rehealing. One of the theory is KTP is absorbed by oxyhemoglobin. So it reduces scar-related angiogenesis. So all the blood vessels which are being blocked, that may get worked up with the help of KTP laser. And again, it acts on the contents of the superficial lamina propria and increase or maybe help regeneration of the defective lamina propria also. So basically, KTP laser, what it does, it gets rid of the scarred tissue because of the thermal energy, and it helps again in the regeneration of the lamina propria. So basically, we are just going to see this clip. From the right vocal fold, you can see a mucosal bridge, which you can separate. You can cut it either with CO2 laser, which we already seen, or with just the scissors. So removal of the scar tissue, and on the opposite side, I am using KTP laser to release the scar tissue from the deeper areas. Again, this is a pre-op stroboscopy. So phonatory gap. And this is a post-op stroboscopy. Again, the mucosal wave you have can be seen. So reduced strain, maximum phonation time is increased. With KTP laser excision of the tissue, we also inject fat to medialize the vocal cord. And we do it on both the sides. Again, this is the only paper which has been published for the KTP laser, but the series was for around 79 patients, and 67 patients improved in single sitting. And one of the author, who is a good friend of mine, from whom actually I got this skill, Hong Sing Choi from South Korea, and he has visited me twice, and you can see him with Mr. and Mrs. Oswal, on whose blessings this was clinic and my practice has settled in Dinanath. Now, I have done around 6 cases of sulcosuchalis using KTP laser, and the results are good. Maybe after 15 cases, I am going to publish my results. Now, again, another thing is basic fibroblast growth factors. This can be used as an OPD procedure, which already Dandan has talked about. I just want to mention this is available in India. The cost is around 1,80,000 for 1 milligram, in which you can have 20 dosages, and you can inject maybe bilateral vocal cords in 10 patients. So for each cord, it comes around 9,000, which is really quite easy to do in our patients also. So it's available in India, and you can use this. We have already talked about it. I just want to tell one point. When you are explaining these procedures to the patient should not feel you are just doing a surgical trial on the patients. So you have to mention with the literature, these are practiced and well-established procedures. Because 1 or 2 patients and from insurance companies, I have got these remarks. You are trying these methods on our patients. And patients are counseled to minimize professional abuse, misuse. In extreme cases, they have to change their profession. And what are the recent trends? Just to summarize, antifibrotic agents which can be given during the acute trauma, in cases of acute trauma, to reduce the scar formation, or when you do surgery for maybe a big polyps, you can inject steroids, or instead of steroid, you can inject antifibrotic agents to lessen the chances of sulcus formation. Mesenchymal stromal cells can be used to regenerate the superficial lamina propria. This is one study which we are doing with one UK company, a jellyfish collagen for soft tissue regeneration in lamina propria, and tissue engineering, which he is trying to rebuild the scaffolds and put them in the lost tissue and inject the fat or put in some tissues there. This is the only mesenchymal stromal cells have been tried in humans. So there is a human trial, and they are showing good result in around 70, good improvement around 60 to 70% of patients. So these are the things coming up. Just to tell one sentence, there are many, I see at least one patient every day of sulcus vocalis because of vocal use, shopkeepers, TV presenters, singers. I mean, they do have this pathology. So we have to find out some method or the other to get rid of this dysphonia. Thank you. Thank you very much for your hearing.
Thank you, Sachin. I think, how long have you got now for discussion?
Yeah, 15 minutes, yes, sir.
15 minutes, yeah. Let me first of all do the summary of what has been presented. The message that I get from this presentation is, first of all, diagnosis is a difficult one. You got to make sure that you diagnose sulcus vocalis, and as I read from the literature, the diagnosis is more certain under general anesthetic when you move the lamina propria on the vocal ligament. So your diagnosis is important. Second message is there are 2 or 3 methods to attack this condition. Number 1 is excise the fibrosis. Number 2 is augment. Number 3 is augment and excise both together, or excise and augment in that order. And number 4, regenerative medicine. That means you excise but provide something which will regenerate the lamina propria. So these are the 3 or 4 methods that are available The next thing that I have learned and saw from the presentation is patient counseling. Patient counseling, I think, is pretty important here because with augmentation, what you're doing is providing volume so the patient doesn't get tired. You're not providing vibration at all with augmentation because vibration is lamina propria. If you don't replace lamina propria, then you cannot get vibrations. Correct me if I'm wrong, but augmentation gives you volume, but not the quality because there still remain the fibrosis. The next message is KTP or CO2 laser. Well, I am a laser man. I started pioneering work long time, 1980. So I can tell you that what you're using is thermal energy, photothermal cutting. It is not, there is no chromophore for KTP. KTP chromophore is hemoglobin. You are not tracking hemoglobin with KTP. It's a chromophore. So there is no specific chromophore either for CO2 laser or KTP laser. CO2 laser chromophore is water. KTP chromophore is hemoglobin. So what you are using is not a chromophore, but a thermal energy, photothermal. It is not specific whether you use KTP. The advantage of KTP is you got a fiber. This is more accurate. You go there without vibration. So this is a very good use of KTP because it's fiber delivered. Whereas CO2, if you go back to Mark's presentation, wherever you see a white tissue next to your incision, white tissue is coagulum. That tissue is already dead. So the white tissue, if you magnify your recording, you see white tissue around your incision, that white tissue is coagulum already formed. So it doesn't matter what you use, there's always a layer of coagulum, maybe 100 micron, maybe 200 micron. That is going to, you're going to lose that because it's dead tissue already. So that's the next message. Now, results, you see, results are variable. Results are variable because pathology is variable. How deep is the fibrosis? Whether it's only in a superficial layer or is extending all the way to your vocal ligament, or is there a defect already? So these are the issues, I think, for young doctors to understand that this is one case where you need a lot of study, a lot of literature uh, study to see what you're aiming at. Like Brandon says, his aim is to augment. That's fine. Your aim is to remove fibrosis and augment. That's fine as well. So these are the things that my observation is, and there is a lot more work, I think, that needs to be done for this condition. There are some questions from the audience. What's the gold standard for the treatment of sulcus vocalis? So, shall I start with Brandon, and then we go around with other people? Same question.
Yeah, sure. I think that to imply that there's a gold standard means that there's a universally accepted and agreed upon treatment. I think that we will get to a gold standard probably in the next 10 years, and I think it's probably similar to what Dr. Gandhi presented. I think it will involve a degree of laser ablation followed by an injection of a modifying agent like PRP and or FAT. But I think that there is still some degree of debate within the literature for us to sort of, say that there's a gold standard. I think is premature.
Sachin?
What I would
Sachin Gandhi, that is.
Yeah.
Oh no, whichever Sachin, go on.
yeah.
I
think basically Sachin has already told there are 3 degrees of sulcus vocalis on diagnosis. How deeper it is. So maybe when it's just lamina epithelium, which is really getting depressed, so it's limited to only the epithelium, and that is maybe class 1 or grade 1 of sulcus vocalis or physiological sulcus vocalis. in these cases, you can start off with maybe voice therapy, vocal hygiene, reduce the strain while they are using or in their profession, the voice in their profession. So conservative methods in maybe type 1 sulcus vocalis. So it's not deep, it's just superficial sulcus. You can start off with this, and if it remains and patient is having hoarseness and is troubling in his profession, so you can have augmentation which would suffice, no need of any dissection, because it's just a dimple in the superficial epithelium. As it goes deeper, that is grade 2 of sulcus vocalis, there is superficial epithelium which goes through the superficial lamina propria and adheres to the ligament. So in those
So
cases,
basically, there is no gold standard. Each patient
it
has
has,
to be
yeah,
treated
yeah,
as you find the pathology.
yes, yes.
Yeah.
So
Okay.
as you go deeper, then surgical treatment would be the some sort of surgical treatment, but there is no definitive thing. This surgery you do and there are 90% results.
So it's tailor-made for a particular patient. And what you can do in your hands also. Your own experience counts.
Yes. And grade 3 sulcus, in which the epithelium really goes down into the vocalis muscle. These patients would need a lot of counseling, and maybe surgical option would be the last option in these cases, because surgical results are really not good in these cases.
Okay. And Sachin Goel,
Sir,
your comments?
I
Sachin
completely
Goel?
agree with what has already been said, sir. Because it is a lot of surgical methods have been tried time and again, and the results have not been 100% in either of them. So it's a science which is still evolving, and we need to study better regenerative materials like growth factors and maybe platelet-rich plasma to give better results.
Okay, thank you. The next question is, what exactly one means by vocal hygiene and how to do that? It's a very basic question, but it's a good one. What is vocal hygiene, Brandon?
So it's a good question to start off with. So vocal hygiene, you want to make sure that the patient is adequately counseled as to how to appropriately use their voice, how to remain hydrated, things like avoiding smoking, things like controlling reflux and making sure that they're not having reflux-related laryngitis. So you want to make sure that the patient understands appropriate voice use with forward resonance and well-supported vocal production. And this is something that, in my practice at least, a lot of my speech and language pathologists will do during their first session with their patients, just because it's very basic, it's very straightforward, and it's easy for them to educate the patient about how to practice vocal hygiene, good vocal hygiene.
Yeah, I think I'll add on to it. Those who are professional speakers, politicians, for example, we tell them to have drink of water often in between the famous Indian politician as a patient, not as a patient, but consultation, but I won't take the name. But he was in Mangeshkar Hospital, and that's what I told him. Drink plenty of water, give pauses when you speak, don't go on firing. That's vocal hygiene as well. Okay. And I think you made a very good point of acid reflux and all that. That's another matter. You can have acid reflux without any symptoms. So let me ask you a cross question on that. You said vocal hygiene, acid. Do you give sulcus vocalis patient antacid and the assumption that he's got an acid but he has no symptoms?
We're rehashing our old discussion last time. I do not. If I see no evidence of or hear any evidence of patients describing their symptoms correlating with acid, either related foods or provoking foods, if I see only sulcus, I don't see significant edema, even though that's not always a perfect measure we talked about last time. If the patients say they can eat a chili, hot chilies, and they don't have a worsening of their symptoms, if it's constant throughout, I do not always prescribe a PPI for those patients.
Okay,
I do
so that's a debatable issue. Okay. You want to add anybody else? Sachin,
Yeah,
Sachin Goel, Sachin Gandhi?
yeah,
Nothing?
I think it is some of them good amplification measures and vocal hygiene. Actually, what we have done to each and every patient who visits voice clinic has been given anti-reflux and vocal hygiene measures as a routine printout. There is always a counseling to each and every patient about vocal hygiene, because I think it's a main treatment which would take care of, I mean, 70-80% of the patients uh, is anti-reflux and vocal hygiene. Yeah.
So do I get it from you that every patient gets antacid?
No, this one, precautions, anti-reflux
Oh, measures
measures
without medication.
without medicine.
Just
But without
anti-reflux measures.
Yes.
Okay,
lifestyle
that's
changes.
that's a good
Lifestyle,
point as
yeah,
well.
lifestyle
You don't
management.
have to give medication, but you tell the patient take care of pillow, extra pillow, and nothing to eat drink 3 hours before sleeping,
Yes.
and no smoking and all that. Yeah,
Yes. Yes.
alcohol, wine, etc. Yeah. Okay. Uh, treatment of hoarseness of voice in phonatory gap. Now, I don't understand that question, because voice in phonatory gap is due to many causes, not just sulcus, phonatory gap. So I think treatment of hoarseness of voice in phonatory gap has been covered more than fully in the lecture, unless you really want to add anything. Because augmentation, thyroplasty, are either transcervical or transoral, is
Mhm.
that what you use is up to you. You can use saline, fat, whatever. So that question has been covered in the lecture. What is the role of speech therapist with vocus vocalis? Sorry, it's a wrong spelling. Vulvus vocalis. It's a vulvus. It's sulcus vocalis. Okay. So what is the role of speech therapist with sulcus vocalis? I think again it has been covered that speech therapist, or voice therapist for that matter, forms an integral part of the management. It's a team who manages, not the surgeon. You must get a voice therapist involved right at the beginning, preoperatively and postoperatively as a follow-up. Brandon, anything to add?
No, I think that you hit the nail on the head. And I think it's been covered as well. I think that there are a couple of techniques, especially as Dr. Gandhi mentioned, for a class one, forward class one, sulcus. I think certainly forward resonance, improved breath support, those types of things can be helpful for those patients in voice therapy. But I think when you're getting to some of the more, purgatory and some of the other sulcus vocalis classifications, I think you need intervention. So,
Okay. Sachin, anything to add?
Yeah, I
Nothing.
mean,
Okay. Let me ask the question about how far you can go of getting patients informed consent. We went through the stage in 1980s maybe, when medical legal issues came to UK in a big way, following, of course, the Americans. So, when you tell the patient, I'm giving you all this information, whose job is it to make sure that the patient understands what you're saying? How do you know that the patient understands what you're saying? He will say yes to anything if he's motivated, or he will ask question, what is vocal hygiene? So who assesses the understanding of what you're saying? It is you. You're a professional. You have to make sure that what you tell the patient actually he understands what you're saying by even asking him to repeat what you said. So there is this medical legal issue, that who said patient understood? He said he didn't understand. The doctor who used all the terminology in medicine. So make sure you know what you mean by patient's consent. It's informed consent also. That's the first thing. Secondly, you have this issue of what exactly patient is asking for to put it right and what you can offer. And again, from the literature, I understand that you can give him the volume by augmentation or successful excision, but you can't really give the quality of the voice. Is there a comment on this at all from any of the faculty?
I agree with you completely. I think the other thing to remember for this is it's usually a long-standing disorder, a long-standing problem that patients have, and they've been dealing with for a while. They've done a number of voice therapy sessions, and so I will oftentimes tell patients to go home and think about things and come up with more questions, and then come back to see me a couple months later to discuss, so that we make sure that everyone is on the same page.
Okay. I think I'll just make last point particularly for the audience of Asia Pacific region. This procedure is not one-off, is it? It's a procedure, maybe surgical procedure, is a repetitive procedure. Do you make that definite with the patient? Because there's a lot of private practice. Of course, there's private practice in America as well, not here in the UK, but American private practice is covered by insurances. How many times do you think the insurances will cover the same procedure, Brandon?
That becomes an issue, and especially with, as Dr. Gandhi mentioned, with what we're doing here with PRP injections, a lot of these things are so new that insurance companies are reluctant to support them, and so patients oftentimes get left with an out-of-pocket bill. And so it is one of those things where we just need more literature, we need more data, we need more science to prove that what we're doing is beneficial. So
I think I told you before, maybe you remember. There's a question of speech therapy. How many sessions do you give? Not this particular one, any speech therapy. When I was attending conference in Paris with Jean Vidbol, American colleague, or maybe Bob Satloff even, he said 6. I said, why 6? Because that's what the insurance companies pay. They don't pay more. So there are many issues. Again, Sachin Gandhi and in that part of the world, you might get a bad reputation that this doctor is not doing job properly in the first place. So he's calling me after 1 year for repeat procedure. So these are the other non-medical issues that you got to take into account as well. I think it's been a wonderful session. I'm sure you agree. Contribution from Mark was very good. And I don't know if you want to say anything more, Sachin.
Abhishek. Yes, sir.
Sachin?
Yes, sir. Yes, sir.
Gandhi. Yeah. You want to say anything more?
Yeah, I would like to thank. There are around more than 700 live participants logins now. I would like to thank all of them. Next session. The next session would be on 18th of May, and I think we'll be discussing pre-malignant lesions of the vocal cords. So there are two things. One, all the talks in previous webinars as well as today's webinar are recorded. This would be put up on the website. The link would be sent to all the participants and all the people who have registered for this by email and WhatsApp. So those who have missed it or don't want to see them again, they can log on to the website and again listen to the lecture. All the details, the speakers and the topics of the next webinar will be intimated around 6 weeks ahead. And I would like to welcome all of you for the next webinar.
On that note, let's end it with a funny note. My colleague here in the UK, he's retired, Liam Flood, you know Liam Flood, of course. Liam Flood retired, and now he is an assistant editor for many, many years of JLO. I asked him, did you see any of the sulcus vocalis patients when you were working? I didn't see, because what brain doesn't think, eyes don't see. Okay? You've got to make sure that you're looking for sulcus vocalis, then you will see, otherwise you see a faint line, nothing else. So I asked him, he said, do you know, Vasant, he said, first paper that came on sulcus vocalis, I thought it was a spelling error. He sent it back. So this was many, many years ago. It's a condition which now exists. Look for it. Use your putty to move lamina propria on the ligament. See if it's moving all along. If it's not moving all along, you got diagnosis of sulcus vocalis. Now, vergeture is straightforward because it's anterior to posterior. But for secondary to any surgical procedure, do use your putty. You know, I did use it, although I was not looking for circumferences, just to make sure that there's no mucus lying anywhere on the vocal processes on the vocal fold before I do any surgery. That's microlaryngoscopy when it came along. And of course, you got the gases going there from the anesthetist and everything else. So I always did vocal hygiene in my own way before I did surgery. And I used 1 in 100,000 adrenaline as well to give me, we're going before laser surgery, okay? So that way you get some decongestant so you don't get bleeding. So these are the little tricks. Well, thank you very much for all of you. Thank you. I enjoyed that thoroughly. I learned quite a few things. Thank you very much. And we'll see you again in May. Okay? Thank you, Brandon. Thank you, Sachin Goel. And Sachin, wonderful job again. All right. Thank you.
Thank you so much,
Bye.
sir.
Bye. Bye.
Thank you. Thank you.
Okay. Bye, Brandon.